Now, can I just say, can you see the whole screen?
Yes, we can. Yeah.
Yes, we can.
No, I've got this little bit to the side here that I'm not sure how to make that any smaller.
So we can only see the slide, so
Good.
fine.
Okay, that's fine. Great. Super. So I thought I'd start off by talking about the multidisciplinary approach to extent 1 to 3 thoracoabdominal aneurysms, and these are what we would call supra-diaphragmatic aneurysms, as opposed to extent 4, which are up to the celiac axis, or infradiaphragmatic aneurysms. These are relatively uncommon compared to traditional, abdominal aneurysms of any extent. We are fortunate in Birmingham that we work in a hospital where we can do the open operations, which you can see here on the left of the screen, and the endovascular operations, which are on the right of the screen. The patient on the left is a Marfan patient who has had an open extent 2 repair, sorry, using a multi-branch Caselli Dacron prosthesis, whereas the patient on the right is a non-Marfan patient with a chronic post-dissection aneurysm who had previously had a TVAR in a hospital in London, and we did a surgeon-modified device to replace the aneurysm from the diaphragm down. So, hot off the press, these are the European Vascular Society guidelines for thoracoabdominal aneurysms. You can see the great and the good here who took all the evidence and came up with these suggestions. The level of evidence is not strong, but it's really based on multi-center studies, and there is no level 1 evidence. What has happened between the last iteration of the clinical practice guidelines and the current guidelines is that the first line approach for thoracoabdominal aneurysms, whether these are degenerative aneurysms or post-dissection aneurysms or ruptured, is endovascular repair. And of course, I'm slightly cynical. A vascular society would say that, wouldn't it? In that most of the operations that are done, open thoracoabdominals, in Britain at least, are done by cardiac surgeons. In terms of trying to find evidence, almost all of the studies are either series, multi-center series of only endovascular repair, and the other studies are multi-center series of only open repair. And there are very little data in the literature. I think there's a couple more papers now looking at what the outcomes of open repair and complex endovascular repair are in the same center. So we'll get onto that in a minute. When we're looking at the thoracoabdominals, this is our method of selecting patients in the MDT. Open repair is the procedure of choice for those under 70. In fact, it's more like under 65. If you've got heritable disease, which is the modern name for connective tissue disease, so we don't really talk about connective tissue disease anymore. Heritable disease, which is predominantly Marfan syndrome, and to a lesser extent, something called Lewis-Dietz syndrome, and some very, very rarer heritable conditions. Post-dissection aneurysms will tend to be done open, and this is partly because, in fact, most of the post-dissection aneurysms are largest in the chest. The largest just distal to the left subclavian, and in many cases, the aneurysm can be repaired through a left thoracotomy without having to repair the abdominal segment. So these aneurysms, albeit that they're thoracoabdominal, if the patient's fit with heritable disease and young, they'll have an open thoracic repair. Also, if they've got a non-hostile field, so if there's been a previous open repair in the chest, then that's where endovascular is most likely to be involved. Everyone before an open thoracoabdominal aneurysm has coronary angiography and echocardiography to assess whether they've got concomitant valve disease or coronary disease. If you've got none of those, then you're a candidate for open repair. If you've got good lungs as well, and if you've got essentially no kidney disease. All of the rest of the patients, certainly in Birmingham, will have endovascular repair if they're anatomically suitable, and there are very few after acquiring a lot of experience. We've done about 1,300 fenestrated or branch grafts in Birmingham. Very few are not anatomically suitable. Age over 70, degenerative disease, hostile chest. If you present acutely or you've got an infective native aneurysm, you've got a high clinical frailty score, you've got a Montreal cognitive assessment, it has to be essentially normal, then they'll have endo repair. We have a cut-off for chronic kidney disease, which is 30. A GFR, estimated GFR of 30 or above is okay. Anything below 30, we really, really need to think very carefully about whether we operate on these people. And it's partly because that is a marker of systemic cardiovascular disease and is associated with a poor outcome. So we're working on a paper of the 1,300 complex and another 700 infrarenals with GFRs, and it shows a very, very poor outcome for people with a GFR below 30. There's other issues to look at, whether we can make the patient suitable for either open or endovascular repair. From the endovascular point of view, we look at the size of the aneurysm to some extent, in that we only really operate if it's above 6 centimetres in men or women. Landing zones are important if we're going to do a totally endovascular repair. And if we can't do a totally endovascular repair, then we combine open and endovascular approaches. So we've got a large published series of patients who've had a total arch replacement with either a frozen or conventional elephant trunk, and the endovascular, the thoracoabdominal is done distally endovascularly. One of the biggest issues for turning a patient down is atheroma. So this is the shaggy aorta, and these patients do badly with either open or endovascular repair. So they've got a real bad atheroma burden, then they probably shouldn't have anything, because they're going to do badly in terms of complications from either approach. Tortuosity is less of a problem with experience, and target vessels, the main issue with target vessels is diameters. So 4 millimeters is the smallest vessel that you would consider for endovascular repair. And that's similar with whichever device you use, whether you use the Cook device, Artivion, or the Tambi, which is the Gore device. 4 millimeters is about the limit. It's not always endovascular repair all the way. You know, we have done operations where we've done the proximal aorta open, we've done the abdominal aorta open, we've done renal bypasses or mesenteric bypasses for target vessels that look too difficult to do totally endovascularly. Shared decision making is very important. If you're in a centre that can do both, then you explain to the patient the short-term benefits of open repair, of endovascular repair, and in some cases the longer-term benefits of open repair, and let the patient decide. I must say, when you're talking about a higher risk of death and spinal cord injury with open repair, even patients who are good candidates for open repair will often decline that and choose endovascular repair. The procedure is important in terms of device design. Branches are good for the mesenteric vessels, the celiac axis, and fenestrations are better for the renal arteries. And this is even right up to the present time with the Tambi device, the Gore device. There's an attrition rate that's remarkably similar to the Cook multi-branch device and the Artivion inner branch device for the renal arteries. So renal arteries do better with fenestrations. Spinal cord protection is important. We do not use CSF drains. We published our experience in 2019, I think it was. We stopped using CSF drains in all thoracoabdominals in 2012. So we've done about 300 extent 1 to 3s without CSF drainage. The luxury of staged repairs in the elective setting or in the acute symptomatic non-ruptured aneurysm. That's the reason why we can avoid CSF drains. So by staging the repair, we'll talk about that in a moment, that helps to reduce the spinal cord risk. And that's based upon animal studies from Christian Etz and Randall Greep in New York from about 2 decades ago. Access is important. Nowadays, we do our procedures percutaneously from the groin. Ancillary kit, we use steerable sheaths, and we very rarely have to come from the arm. And if we do come from the arm, we access the right axillary artery because it's on the same side that we're standing to do the groin approach. So this is a paper published in the European Journal of at the time up to December 2021 to almost 300 extent 1 to 3 thoracos. And you can see that there's some big differences. The median range of age, the open repairs are over 2 decades younger. That's important. Endovascular, we're doing slightly bigger aneurysms because they're predominantly degenerative. Most of the people with heritable disease and chronic dissections, as I said earlier, are done open, but not everybody. If we move on to the comorbidities, far more patients with chronic obstructive pulmonary disease treated with endovascular repair, and again far more with coronary artery disease treated endovascularly, and patients tended to have worse kidney function. So you can see that we're obviously picking the patients properly, and that the more comorbid patients are having complex endovascular repair. We talk about spinal cord protection. This is our spinal cord protection protocol. It's all really about trying to preserve the blood supply to the left vertebral, or the predominant vertebral, which is predominantly the left, and the internal iliac arteries. We do staged operations. They go to HDU for 36 hours after both stages. They sit at 30 degrees. That's partly so that they can breathe a bit better, they can eat, they can drink. We're trying to maintain their oxygen delivery, hemoglobin above 10, and there is evidence for that. The hematologists will try to say what's the evidence, because everyone else gets a hemoglobin of 7 or 8 as a transfusion trigger, but there is evidence for a hemoglobin of 10. There's a paper from the American Research Consortium on Complex Aneurysms, and all the 10 units that have access to their device exemption, the Cook device, use an hemoglobin of 10. Obviously, treat the coagulopathy. These patients have big aneurysms and they will consume factors. So coagulopathy is it's not common, but it's not absent. And then after 36 hours, we sit the patient up in bed. Later that day, we get them out of bed and get them walking, and we'll often have them walking and ready to go home at about day 3 or 4. And we don't use prophylactic drains, which makes a huge difference to the burden for the nurses looking after the patients. This is an example of staging of those 220 odd endovascular repairs. This is how we stage them, and you can see that predominant approach to staging is to do a TEVAR first, with or without a left carotid subclavian bypass. It's fair to say that over the last 5 years we're doing more of the left subclavian endovascular approaches rather than using the bypass. And then with some of the other patients, we'll do the fenestrated or branch graft and leave a limb or leave a branch. All of this is decided by looking at the CT scans before. If you have a very big aneurysm with lots of thrombus and there are no intercostals and there are no lumbars coming off, then you do not need to stage them. You just do a quick operation because there's nothing that you can preserve. That's not often the case. Often the case is that they do have some, say, large lumbars, for example. So you can do the TEVAR, or you can do the fenestrated and branch graft, preferably the branch graft, and leave the celiac axis branch. And that's the one that you'll fix 5 to 7 days later. If it's a gap between the TEVAR and the complex repair, we go for about 4 weeks if we can. So this is a typical patient, a 76-year-old man with an asymptomatic large extent 2. He's got Parkinson's disease, so he's not a great candidate for open repair, diabetes and hypertension. We do a CPET. So he's had a good CPET here. His RER is 1.23 and he's got a VO2 anaerobic threshold of 10.9 and no other particular issues. So he's a good candidate for open. He's for endovascular, sorry, with a VO2 of 10.9, he's probably not a great candidate for an open repair anyway. That's just sort of borderline for when we would do an open abdominal or an endovascular abdominal, never mind an extent 2. This is how we stage them. So on the left, you can see that's the left carotid artery. And what we would do is we do the left carotid subclavian bypass through a supraclavicular incision. We suture on the 8mm dacron to the carotid artery. We don't complete the distal anastomosis. We puncture the dacron and almost use it as a conduit. And that's a 4 French sheath. I use that to do an angiogram to allow us to deploy the TVAR bang on the money on the left carotid artery. And also potentially, if you slightly cover it, we can do a parallel graft in the carotid, but that's not very common that we ever need to do that. And then what we've done on the picture on the right shows a sheath in the carotid artery placed at the point where we would do the arteriotomy and the anastomosis. And from that sheath, it's an 8 French sheath, we place the Amplatzer occlusion plug. Then we take the sheath out, we've clamped, and we extend the hole from the sheath to make it into an arteriotomy. And then do our bypass, the distal anastomosis. That's the first stage. Second stage, this is a combined graft with branches and fenestrations. We always get regardless of what we do, fenestrations, branches, we always get the superior mesenteric artery first. So this is a graft. You can see a branch. If you can see my arrow, this is going to be the branch for the celiac axis. So we've got 3 fens. That's us just stenting them. Sorry, it's not subtracted. You can see the gap between the fens and the renal. And then we use a steerable sheath, 16 French steerable sheath, Aptus sheath, to get into the branch for the celiac axis. And what we do for this one, again, I'm not sure why we did 3 stages. We don't often do 3 stages anymore. We've placed the distal body and the right limb, and we've left the left limb. And then 1 week later, we completed with the left limb. He had no complications, no paraplegia. The slight problem with staging is that there's always a risk of interval rupture. So this guy was treated over, you can see it's 8 weeks as 3 stages. And we've published a paper on this, particularly with, we looked at our frozen elephant trunks and distal repair. So we now have a policy that we try to complete within 4 weeks. But again, it's logistics more than anything, but yeah, 4 weeks. So these are our outcomes. In this series, if we looked at all the elective aneurysms, the elective mortality was just over 3%, 6.5% for open, and 2.3% for endo. And this compares with other series. The mortality for open repair published from Liverpool is about 15%. The mortality for open repair published from Edinburgh just in the last couple of months is 25%. Ours is 6.5%. And it's because only 30% in our experience will get an open repair. If you look at the emergencies as well, about 30% are open, 70% are endo. If we look at the over 70s that wouldn't get an open operation at all, the mortality is 3.7%. And if we look at the effect of the spinal cord protocol, we can see the significant difference when we ditch the drains and went to staging. Of the first 12, we had 3 paraplegias, and of the subsequent amount of elective patients, we've only had 2. For the non-electives, the mortality is 20%. That's overall, which when you actually think about it, I think the mortality for an infrarenal aneurysm rupture is about 20%. So these are fairly highly selected people, and I'm not saying they're all ruptures either. There are acute symptomatics and ruptures in there, but the vast majority will get endo. This is the midterm outcome of the whole cohort. If you combine them all, because this was a study looking about the complementary roles, the 5-year survival for extent 1 to 3 thoracoabdominals with a very good follow-up, 52 months, is 69%. For the young people, remember they're 22 years younger, we've got an 87% 5-year survival. I think in Edinburgh, again, their 5-year survival for the extent 1 to 3s was about 70%. And again, that's partly because of the large early mortality. And for complex endovascular repair, it's 64%. This is the emergencies? Yeah, I can't even see the title of it. Yeah, I think this is the emergency ones. The mortality rate is, no, this is for age, sorry. If you're doing an operation in a less than 70-year-old, forgive me, for endovascular repair, there's no real difference in 5-year survival. That's pretty important, 88% against 84%. So you could offer complex endovascular repair safely to younger patients. They will do just as well as open repair. So these are quite novel data. If you look at the post-dissection aneurysms, again, the 5-year survival, there is no difference between open repair and complex endovascular repair in terms of 5-year survival for a post-dissection aneurysm. We've done quite a few more than these now. This is the non-elective repair, and this is the bit that's quite insightful. All the effort we put into treating emergency extent 1 to 3s. If they're less than 70, that's fine. You've got a 65% 5-year survival. If they're over 70, the 5-year survival is pretty awful. So the reflection on that is whether we should be operating on these patients at all. It's very different from fixing an infrarenal aneurysm or a juxtarenal aneurysm, an extent 1 to 3. And again, almost all of these will have had endovascular repair. So this is what should be happening. This is the politics of it all. This is what should be happening in the UK. I was part of the clinical reference group for cardiac and vascular surgery about 4 or 5 years ago, and we got almost to the point of commissioning thoracic and thoracoabdominal centres. And the bottom line was that every unit that was treating extent 1 to 3 should be able to offer open and endovascular solutions. That allows you to have a proper MDT. You can treat the patient in any way appropriate because you have people that have the skills to do everything. But it never happened because I think it was people down south in London didn't feel it was a thing that they wanted to happen. Because at the time it was going to be units in Newcastle, Liverpool, Birmingham, and 1 in London. And I think that's what stopped it happening. So in conclusion, at least in our experience, and it should be, that open repair and complex endovascular repair are complementary. Open repair for the young fit patients and complex EVAR for the older, less fit patients, although there is a bit of mission creep in that we are operating on more younger patients. Complex EVAR is the procedure of choice for the older patients, but as I say, it could be used more often in younger patients, but only as part of an MDT process. The problem with the emergency repairs, is it worthwhile operating on people over the age of 70? I'm not sure. We'll carry on doing it, but I think it's all about shared decision making and consent, in that they are not going to live very long. The chances are they've got a 1 in 4 chance of living 5 years. But I guess if you've ruptured, then maybe that's a chance worth taking. Okay.
Thank you very much, Noel. Very insightful as usual. So I'm going to start the questions here. So where do you see the future of open repair for extent to repair in the UK in the next 10, 15 years?
I think it'll be centralized. I think there'll be one center or two centers. There'll not be ever be one center. I think there'll be two centers doing it because the numbers are so low. We published our series, which was the biggest in Europe, of Marfan and confirmed Marfan and Lois Dietz open descending thoracic and thoracoabdominals, and it was over 20 years, and it was about 65 patients. That's the distal aorta. For the proximal aorta, every cardiac centre will do an aortic root replacement or a hemiarch or a total arch. It's the descending thoracic bit. And Liverpool, again, published their series, which was over a slightly longer period, 50 patients. So that's the future. There'll be 2 units in the whole of England, or Britain, I would say, doing it because the numbers are so small. There can't be 1 unit because that's a risk when it comes to
geographically it's going to be difficult, isn't it, to get
Well,
those
it's a risk of healthcare having 1 unit doing it. It doesn't, nothing can work that way. So I think that's the future, and I think with the endovascular, if one is prepared to accept that there's a higher re-intervention rate with endovascular repair, then, but it doesn't, the interventions aren't associated with mortality, and you're willing to accept that that means they're maybe a bit more expensive, but I'll bet they're nowhere near as expensive as an open thoracoabdominal. That's usually in hospital for 4 weeks, in the intensive care unit for 7 to 10 days, and still has a, 5 to 10% risk of a spinal cord injury, which costs millions. So I suspect it's that's the only future. Someone's popped up there, say about endovascular for Marfan. I
Yeah.
think that's fine if you've done I'm a bit old school. I don't think it's a good idea doing it into a native aorta. So the problem with Marfan is that they present with dissection. We get them, the descending aortas dissected. Currently, none of the endovascular grafts, the IFU for any of the endovascular arch grafts, none of them say to do it in a patient with a prior dissection unless they've had the ascending repaired. It's the same with the Go or same with the Cook, same with any of them. So I think it will have a place, but it will be in patients with a replaced proximal aorta.
Because of the proximal seal, yeah.
At the expense of, and this has been shown again in the literature, a higher re-intervention rate on almost every target vessel. This is the problem. It just isn't stuck to the aorta. It's a problem with the renals, the SMA, the celiac, the iliacs particularly.
Couple more question from the team here. So patient with ruptured AAA, unfit for open repair, with hostile neck, not fit for standard EVAR. How do you treat him, and what's your evidence to support that?
Well, you know this, Amro. You can answer that question. Well, we have a standard operating procedure in Birmingham in that we take referrals, but if we're going to do a complex endovascular repair, we will not do it after midnight. We'll do it before midnight, and we'll do it from 8 o'clock the next morning. I think we have done, and we're working on a paper on this at the moment. We've done 175 surgeon modified devices. So if that patient has no neck, or the patient has a short neck, an off IFU neck, say 3, 4, 5 millimeters, you know what we will do. We will buy time and we will place an infrarenal graft in there to save the patient's life on the day. Keep it simple. KISS, keep it simple, stupid. And that's no insult to anyone in this meeting. It's what I was taught. You might have been taught as well from your bosses when you were, doing an appendix or doing a perf DU. Just keep it simple. And it's the same. But if they have no neck, then we will do a surgeon modified device. And we've done about 170 odd of those. And the interesting thing is that we're looking at only the fenestrators. We've done about 920 CMD FEVARs, and we've taken out the branch grafts, which is about 200, against 160 odd, 170 PMEGs, and we've done propensity score matching. I'm just talking to one of our colleagues tonight about it.
Just
And
the unpublished data, yeah. So this is the
unpublished
first
data,
period, yeah.
that we're going through the proper propensity score matching of it, and there is no difference in medium-term outcome for the PMEGs that we make, bearing in mind they're urgent and ruptures against the CMDs. So that's in terms of reintervention and target vessel reintervention. There's an obvious difference because the CMD FEVAR's mortality is 2%. For the emergencies, it's about 6 or 7. So if you take out the mortalities, then the survival curves, there is no difference. And what we've also shown is that if we have an off IFU aneurysm that we have to clamp above the renals and it's a rupture, the mortality in our hospital, there's not much on this in the literature, is 50 to 60%. If you clamp below the renals in a rupture, certainly in our hospital, it's 20%. If you do a surgeon modified fenestrated stent, okay, it's patient selection, of course, the mortality is 15%. And that's where the big gap is with emergency aortas.
Okay, one last question for me. If you compare your practice now to your practice,
Ahmed's got a question, so stop hogging it.
Been raising my hand for Labak.
yeah, go for it. Go over that. Sorry.
Right, thanks, Donald, for a nice presentation. For the first thing about the MDT criteria, you said the patient, you put like 70 years old as a marker for having either endovascular or either open. What if you have like 73, which is really fit, which we usually in our centers we have a complex aortic MDT with open aortic team as well,
I'm
cardiac.
with Jeff, yeah, Jeff.
And if it's, yeah, Jeff Sang. And usually when we have like a 76 and he's quite fit, he's just like, look, I will do it open. And yeah, the patient do fantastic in this kind of situations. Do you apply this rule for every patient you have, or is it only for the?
No, I think it's they've got to be fit. There aren't many 76-year-old men with extent 2 thoracos that are fit. But if they are exceptionally fit and they know the risks, so we'll say that our mortality is 6.5%, spinal cord is about 5, and you say, and if you're fit, then if you have endo, it's 2, and your spinal cord rate is 1.5.
Okay.
That's really quite different, and that's only because we've been doing it for first complex endovascular repair for a thoraco was 2009, so we've got 17 years experience, so we have the numbers. And then if we show them that the survival curves for the under 70s are the same regardless what you have, in Birmingham at least, then very few will go for open. And I get that. And I know in Southampton you're developing the complex endo program. I get that. And you've not got the benefit. You're not as old as I am. You've got a few grey hairs, but not quite as many. And I think with time, people like Jeff will retire. You
Yeah.
know, and there'll be very few younger surgeons. We've got Eshan and Aaron. Eshan's probably the youngest cardiac surgeon in the country doing open thoracos. So he's, from our point of view, is going to be around for quite a while. Jeff isn't. Don't tell Jeff that. I know he's fit and healthy, but so it's who comes along. This is important in terms of politics. Which young cardiac surgeons come along and stick their heads above the parapet in today's climate and take a 10% prophylactic operation mortality rate, for example. It's more than that. Look at Edinburgh, 25% in Edinburgh for prophylactic open extent 1 to 3s. Not many people are going to do that. But the cardiac surgeons have a very different mentality from vascular surgeons.
Oh, yeah.
We like lower mortalities. They're used to operating big operations with bigger mortalities than us. But I think and it's about saying to the patient what your results are.
Yeah,
And it's about having your own results. That's the key thing, isn't it?
it is. But the second question is for me quickly. For our fan patients, you rightly said about the reintervention rate for the renals and viscerals.
Yeah.
We have seen that in a few patients that we did. When you plan for the bridging stent, you bridge into the vessels about 2 centimeters? Some people said you have to have like an over, like taking the landing zone into the viscerals a bit longer than
Yeah.
you should do for the FEVAR and for the normal person.
Yeah, that's right.
Yeah.
You need as much length as you can.
Yeah.
and even then, you're going to run into trouble. That's why I think it's really not. I think and the numbers are so small. I mean, this is for you, presumably it's Marfan patients that have got hostile chests, so they've got the old visceral patch that they're not going to get in the future. They'll all have the Caselli graft. And we've not done many of those, I think 5 or 6 at most for
Mhm.
visceral patch aneurysms. So yeah, it's an interesting thing, but it's not going to be, no one's going to make a practice of stenting these ones because there aren't many around. Did you
Good,
have another
thank you.
question, Amro? You're on mute. I love saying that on Zoom.
It's the same question that Ahmed asked essentially, so I think you've answered it quite clearly. I
I
know
think,
you've got other commitments.
yeah, I'm just going to say with in Birmingham, it's very much with the thoracos. Remember, we're vascular surgeons, and most of us are not used to doing open thoracos. So with Birmingham, it's very much that the cardiac surgeons will get the first bite, if you say what I mean, at the thoraco-abdominal. So we will be very much led by them, and we will, if they don't think the patient's a candidate for open, then we'll do it complex endo. It's not usually the other way around. That's their territory. We've got history. Jeff trained up, spent some time in Birmingham.
Mhm.
So it's their territory, really.
Yeah.
Got
More
one one more question from Muhammad Al Ahwal. How are you, Muhammad?
Very well. Thanks, Amr. Thanks so much, Donald, for a lovely presentation. Don't
Aye.
want to take up too much of your time, but again, on the same point of the heritable aortopathies, do you think there's going to be more mileage in converting the extent twos into fours and getting
Yes,
away
yeah.
from the
Def,
visceral
def,
segment issue?
well, definitely. Well, even with the FETs. So if you would use the FETs, and I'm trying to remember, Martin Cherney published on this first of
Yeah,
all. The FET essentially makes it a type 3, so that's a good start. And Martin was one of the first to describe it extending with a TVAR to the crus,
to the diaphragm. Yeah,
and then doing open type 4s. Yeah, and I think that's probably a good way to go. We don't do that. The other way is the thoracic flow, the reversed
yeah,
device that the Vascutech makes. So we've done a few of those, or not a few, I think 3 or so in Birmingham as well. So again, it's about, as you say, it's about avoiding opening the chest, and that cannot be a bad thing.
definitely.
Ehlers-Danlos. There's a question there about Ehlers-Danlos. I think we've never done a thoracoabdominal Ehlers-Danlos endovascularly. I think there's been one we've done in our whole series, one open thoraco Ehlers-Danlos, and we've treated a couple of ruptures with endovascular techniques in Ehlers-Danlos, but that's infrarenal ruptures. I think that's evidence-free zone, I'm afraid. And since someone asked about anticoagulation, is that someone asked about, did you want to know about intraoperative anticoagulation or post-operative?
I think it's a little question about anticoagulation. I think probably it's going to be post-operative, and I've answered it. It's just antiplatelets. There is no evidence
Yeah,
of
yeah.
anticoagulation in these patients.
Just antiplatelets, best medical therapy. Usually clopidogrel nowadays, but yeah, no anticoagulation.
Thank you very much, Donald, for a very insightful talk as usual. It was a pleasure.
It's a
I've
pleasure.
I've picked up a lot as well
Ah,
as
God, you
usual.
know, you know it already. I would have given you the talk, and you could have presented it.
Um,
Thank you very much, Donald, for
Okay.
giving us your precious time on a Sunday
I'll
evening.
I'll I'll hang around for a little bit longer, so I'll just go silent in the background. Okay.
Thank you very much.
Thank you. Thank you for asking me. I appreciate it.
Always a
Thank you.
pleasure.
Thanks for coming. Thank you.
Okay, next is Mr. Ahmed Al-Basti, consultant endovascular surgeon in Southampton University Hospital, and he's going to speak about the MDT decision making in arch disease.
All right, let me just trying to share.
Yeah, we can see your screen.
Can you see my screen? Okay, perfect. Thank you, Amr. Thanks. everyone for inviting me today. And just I think I will go from my presentations about why we need endovascular for the aortic arch aneurysm repair nowadays, the challenges that we face, and how we managed to treat a lot of patients that was actually a turn down before into our practice by using these techniques. So there is an increased number of high-risk patients. They are unfit for open arch replacement. And the other thing is that redo surgery, which you can find in different aspects, patient who had like an ascending repair or hemi-arch repair or having a lung transplant before or any operation of the cyst that make the cyst is a quite a hostile field. So that's another paradigm why we need the endovascular interventions. We have multiple technological advances nowadays that can help us in treating these patients and the potential for reduced preoperative morbidity and faster recovery in these patients. So if you look at the data about these kind of interventions, this is, I think, one of the largest study that has been done in the aortic arch, been combined very high prestigious endovascular leader in the aortic surgery. And you can see that the mortality and stroke and spinal cord ischemia for this patient are quite low compared to the open surgery. And also the only thing that can have a trouble is a late reinterventions rate, which is quite high, about 1/3 of these patients, which is a common thing in any endovascular interventions. So we have actually moved from having an open repair for this kind of disease into the having a frozen elephant trunk, which we usually, it's a common practice nowadays for most of our patients. And then moving to the endovascular approach of having like multiple grafts you can see there between Nexus, Zenith, TAG, Gore TAG, and Relay Plus from Trumo. Before you decide to do any treatment for your patients, you have to know the IFU for each device. So in the market nowadays, we have three main devices. We have the Trumo, we have the Nexus, we have the Cook. And you can see from there that most of the patients most of the diameters in the aorta that actually within the IFU of the most of the graft, you have to have at least in the ascending anything 40 millimeter or low, because more than that, you are actually, there is no graft to cover this. The lens itself, it has to be at least 40 millimeter as well. And you have inner curvatures, outer curvature measurement that you have to bear in account because they are totally different and they are devices that actually you have to have both like Nexus graft in order to know if the patient is suitable for this kind of interventions or not. And also the diameters of the brachiocephalic trunk, diameters of the carotid, subclavian, they are all in mind. So what are the challenges that we face into the aortic arch endovascular repair? We have proximal landing zone if you have a king graft like the one you have here. So it's quite challenging to have a good sealing. You'll have more of a bird beak in this kind of patients with type 1A, which is difficult to repair. If the patient has a mechanical valve, and I'm not sure about the other experience, but if in our center it's becoming a no-no interventions because of multiple problems that happen with the cardiac surgery. It was a cardiologist when they're trying to cross a metallic valves in one of their like adventurous operations, and they caused damage of the valve, and patient unfortunately have a severe aortic regurgitation, died. So in our situations, in our institutions right now, we don't do for in a patient with a mechanical valve if you need to cross the valve. For other things like supra aortic branches, if you have a dissection, the supra aortic branch, that makes your landing zone quite difficult, and you have to create extra anatomical bypass to deal with this. If you have a separate left vertebral artery coming from the arch, and here's come the dilemma between covering it or not covering it. Is it dominant or not dominant? And some people say you can cover it without a trouble. Some people said, no, we have to do a vertebral, either carotid bypass or vertebral subclavian bypass, whatever you prefer. and before you intervene, and or you can include it in the branch if it is like a big diameter, as if more than 5 mm. And the last thing is having a distal landing zone. I think it's a common thing you see in a patient with dissections. So the dissection usually extend distally, and you try to seal the proximal entry tear, and in the distal part you still have some flow coming from below, which if in case of aneurysmal disease, you will have direct flow coming from below, like type 1B endoleak, and that's need to be addressed. Other things, having descending aneurysms, as Donald said, we can do it as a stage procedures later on. So just to give you cases that we've done, that was one of our first cases. She's an 83-year-old lady, really fit, has only hypertension as a background, and she has an ascending hemiarch repair for acute type A aortic dissection 2015. She was followed for a long time, and the aneurysm has started to grow from 5.5, 6 centimeter, and reached 6.5 centimeters. And then from the cardiac surgeon said, we're not going to operate in 83, and it's a redo surgery. So she's really fit lady, involved in many charities. Do you have an options for her? And at this time, we have a look at the scans. Yes, as you see there, you have the angulated neck second to the repair, and whatever you tell the cardiac surgeon about trying to correct it and make it more straight, they will never do it that way. They said, look, how the graft configuration is doing, it has to be an angulation at the ascending component, and we can't overcome this. So in these situations, we decided to go for endovascular repair after counseling with the patients about the risk of strokes, and this is like an early cases that was our first experience, and she agreed to go ahead with the procedures. So we did a lift subclavian carotid bypass, and we used to have like a nexus due 2 branches, one to the subclavian artery and one to the brachiocephalic artery. So that's a design of the graft. The Nexus graft has, for the one who don't know, they have actually a main body graft, which is a branched graft, and they have an ascending component which we extend after we deploy the main graft. And that was the end outcome for her. So she has 2 branches running into the brachiocephalic, one to the left subclavian artery, and the bypass is working very well. I was quite worried about this patient, but next day I was see her like sitting in a chair in the ITU saying, why I'm in intensive care, I need to go home today. And 48 hours she was actually home. So in an 84 or 83 years old, that was quite unusual. And that's her post-op CT scan, which shows that the aneurysms has sealed completely. And then come to another challenge that we have seen as well. If you look at this situation, the patient is a 72-year-old lady. She came to our hospital with acute chest pain. And we did a CT angiogram for her. And as you can see, she has a huge descending aneurysms coming, following the dissections coming from the distal to the left subclavian artery. And that goes all the way down. As you can see, that's why we're talking about the distal landing zone. And yeah, just to accelerate that. Yeah, so it goes all the way down to the abdomen. And she was seen by our cardiac surgeons as well. And the problem with this lady, I will show you later the reconstructions. She has many challenges in terms of anatomy, and given her background of hypertension, chronic kidney disease, atrial flutter, and she had a previous ascending hemiarch repair. So they said she's a really high-risk patient, and we're not going to touch her. And the plan then was a team for turning down. So you can see there she has 2 angulations. You can see one angulation there just distal to the origin of the subclavian artery. We have another angulation at the ascending hemiarch, which is usual for these cases. And for her, given that actually her chest pain was increasing, and I had a look at her next day, and we decided to do like a total debranching between carotid subclavian bypass. And we said if she managed to recover from this kind of interventions, it means she's going to be fit enough to have that kind of treatment, and we don't have any other options. And after counseling with the patients and the family, she decided to go ahead for it. So we did an endovascular repair with a Nexus 1 graft as a brachiocephalic. So we did the debranching 2 days before, and then after 2 days, we have the endovascular interventions. The extreme angulations, we needed to use two sending component because the first one actually has caused like a large bed peak, and we have to complete it with another ascending component. And finally, after you deal with this down to the chest, you have to close the back door, which is a false lumen. We use the Cook distal aortic occluder, which thankfully was available in St. Thomas's at this time, and we managed to get it from them. And that was the end. So you can see there the branch going all the way to the brachiocephalic, and then the bypass is not in these pictures, I'm sorry. And distally, you can see the distal occluder device here, which we occluded the false lumen. And actually, that has sealed the aneurysms completely. And then that's the post-op CT scan, the configuration of the stents and the sealing of the aneurysms. I was actually expecting to have like some sort of endoleak, but actually, it was quite a good outcome in this patient. And the last one is a 58-year-old gentleman who, again, presenting with expanding aortic arch aneurysm of about 70 centimeter in diameter. So that's the kind of patient that 58. He has actually a previous background of hypertension, COPD, chronic kidney disease, and he has an ascending aortic repair for type A dissection in 2017. Following the operations, he has some sort of like massive stroke with residual weakness in his left leg and right leg and right arm. And since then, he has been declining in terms of general fitness and health in the last like 5 to 6 years. He was seen by the cardiothoracic team, and as usual, they weren't happy to operate on him, given his young age. We have a strong debate between us, and they are not interested in treating him. So the problem with him, as you can see in the CT scan here, focus on in the carotids in the right side, you will see there is a dissection, the carotid artery, internal carotid artery, brachiocephalic artery dissection with an aneurysm here as well. And then a dissection extending all the way down with a huge aneurysm in the descending. So in this case, we have a problem. The problem is that we have to overcome the dissections in the brachiocephalic artery, and trying to isolate the aneurysm. At the same time, we have an internal iliac artery, internal carotid aneurysm, internal carotid dissections from the brachiocephalic all the way up to the nearly C1 level. But the internal carotid artery was dissected, but it wasn't aneurysmal. So the plan is, if I need to land it somehow, I need to land it in a healthy artery, which was the right subclavian artery that time. So my decision was to stage the procedures, is to do from the right subclavian artery to the true lumen in the left internal carotid artery. And that was done intraoperatively by identifying the force from a true lumen with the ultrasound scan to make sure I'm not implanting the bypass into the false lumen, and I am on the right side. So we did the first operation, went without a problem. And then we decided to go for a trio graft. You can see it from the right side there. It's 3 branches, one to the right brachiocephalic artery, and one to the left carotid artery, and one to the left subclavian artery. So we did that, and the patient in the first 2 hours he was quite well, and then he had a stroke. And unfortunately, the stroke I was expected to be from the right side, but it actually happened from the left carotid. So it's actually despite having residual weakness before, but actually he was not able to move his hand or leg at all at this time. So we decided to treat it conservatively because there's nothing in the CT brain, nothing in the graft in the CT scan was quite normal and open, and patient recovered after about 2 weeks in the ward with medical treatment back to his baseline. So you can see it is not simple procedures. It requires a lot of planning. It's a high risk procedure as well, especially in this kind of patients. Currently, because we have a strong cardio thoracic team, we only left over with this kind of patients with severe angulations, with problem with the dissection extending all the way up to the up the cranial branches and up to the neck branches. So in this situation, you have to think outside the box and trying to create solution for these patients. However, as well, you have to be realistic. And I have to tell you that we totally did around like 12 or 13 cases right now. And I have turned down more than this because of they trying to push the power from our side or push their patients away from us. But we turned out a lot of these patients as well. So it's as I said, it's not one man show. We have a cardiologist team that's doing the job of pacing, and for us, we have the cardiothoracic team that we are usually having a direct conversation with them, and we have a complex aortic MDT involving Brighton, involving Southampton and Oxford. That's happening every 2 weeks to discuss this kind of patient reach solution. And yeah, and the whole team is really important in planning an MDT, in planning this kind of cases. And yeah, that's my presentations. Thank you very much.
Thank you, Ahmed, for a very excellent presentation, a very complex topic as well. And I'm glad Donald's still around. I'm guessing he would like to comment or ask questions.
I think it goes back to what I said before. I think when Jeff retires, we're going to have more of these to do because I think that's the issue. We when we had Bob Bonzer and George, a lot of the cardiac, they're really happy to do third, second, very rarely third, but redo sternotomies. And Eshan and Aaron still will do redo sternotomies into a tar and fet. And I guess that's often where you get most of the work is for the people that they do not want to do a redo sternotomy on. And I know
Yeah.
Jeff will be very capable of doing that as well. So you do get left, as we do in Birmingham, you get left with the worst possible cases.
Yes. Yeah.
And it's not a level playing field. But you've got to put into context. We published with Liverpool the combined series of our FETs with distal disease, the mega aorta, and it's still a 7 to 8% mortality with a frozen elephant trunk. This is when you're treating people that have got the whole aorta affected. So I think that's as good as you could possibly get is to try at least be equal with that. A 10% mortality for these complex art cases. You're on people that are far worse than the cardiac surgeons wish to take on, and you're probably doing well then.
Okay, thank you.
That's what I think. I mean, I think we get all the horrible ones as well, and they do have a problem with stroke. Stroke is perhaps the biggest issue. And yes, they do recover, but it doesn't help. You don't feel very good about it,
Oh,
for a week, and then they get better, and it's like, well, the CT's normal, all the branches are normal. We've had them happen a stroke, 2 or 3 days later. I don't know. It's an enigma.
yeah.
It's one of those things. But no, good on you. Obviously, that's the device to go for then for the urgent cases is that Nexus device.
Yeah, and to be honest, we use the as well Gore TBE, and I think
Yeah.
more as well in Brighton use the Gore TBE in these cases where we
Yeah.
couldn't find to have a nexus. But yeah,
I think I've always been a bit reluctant to do the carotid subclavian bypass because it seems such a, not technically a difficult thing to do, obviously, but
the bleeding issue, I
it
think.
it makes it a little bit more invasive, doesn't it? And I think that's where your two or three branch devices with the Nexus is the way to go if you can, isn't it?
Yeah.
I'm going to shut up now and let other people ask questions. But well done.
Well,
Good
before
presentation.
I get more to ask his question, I've got a question not just to Ahmed, but to the whole panel about how do you reduce the risk of stroke? I think in the literature it's between 3 and 12%, isn't it? So what's your stroke reduction strategy in these patients?
Yeah, to be honest, it just if you because I've used heavily Nexus device, they said about the triple flushing and double flushing in the device, and it will help to reduce the air bubbles, stroke, and they claim that it has reduced the risk compared to other device between like from 10% or 8 to 10% to 3%. But yeah, I did 13 cases and I have one case of a stroke. So other people talk about CO2 flushing, and when I used to have that fellowship in Hamburg, they were actually doing a CO2 flushing for all the devices that they use, and they think it's reducing their risk of having a stroke. So, but I mean, if you have for dissections, it's uh, uh, I think the stroke rate is lower compared to aneurysmal disease and having a thrombus in the arch and things like that. But less manipulations of the device into the aorta, and I think it's something that you should think of, especially if you use like a through and through wire, like in Gore TBE. And if you have to manipulate the device to get the wire in the right corrections, you have to manipulate in the thoracic aorta down there, not in the around the arch level. So that's the thing that we do, trying to reduce the stroke.
And do you use ACT with your heparin, or how much heparin do you give in these cases?
Yeah, we use ACT. We target between 250 and 300 in these cases. Yeah.
I think
Donald, yeah,
patient selection. It's like
Yeah.
everything.
Yeah.
choose
Yeah.
Pick
choose the
winners.
winners, yeah.
Pick winners. Yeah, I mean everything else is not going to compensate for picking losers. So pick winners. And I think what you're doing, Ahmed, as well, and you say and that's really important because we don't have a really good handle on turn downs. We have a better handle. We started collecting data maybe 2 or 3 years ago, but turn downs and turning down, you say you're probably operating on less than 50%. That really is important. So you are picking winners, and hence your results are good, which is exact. We don't want to cause harm.
Yeah.
And I think the good thing with your Nexus device, just to say another thing, is you can't lose if you're picking people that have got symptoms or they're going to rupture. So that's another important thing to do. Do no harm because you're not going to do any harm to those people. It's the elective ones that are high risk, that are not winners.
Yeah.
It's easy to get carried away with the rush of the technicality of doing a complex repair, but it's not good if the patient dies or has a stroke.
Yeah.
That's
Mo,
my wisdom.
what's
Thanks,
your
Ahmed.
stroke reduction strategy in Brighton?
It's exactly the same as Ahmed was saying. Mainly keeping an eye on the CT. The ones with the shaggy arches, they're the risky ones. And again, if you're going to use a through and through wire, don't unwrap or do anything in the arch. Try and do it in the distal descending. Um, the other thing I wanted to ask Ahmed, now obviously you've used Nexus quite a lot. What do you think about the dual component ascending and graft as opposed to the single component ones? Do you think there's any longer term issues that we might not be seeing yet? Because I know the ascending graft is very soft and floppy. How do you think that compares to something like Hector?
Um, to be honest, I having the ascending component is the only downturn of it is that you have to do a lot of is unlike like the Gore TBE or any or Cook or something like this. You have to do a lot of pacing, just because the graft itself it takes sometimes to open it, the ascending component. That's one thing. I haven't seen any like because the overlap between the ascending and the branch device It has like a double techniques of like the hooking, and the overlap is about 20 millimeters. It's quite stubborn, and I haven't seen any like endoleak between this kind of problems. Having a floppy ascending, it helps in this angulated cases that you have seen. It just take the conformability of the artery quite well. But sometimes you have to use two ascending components, and that gives you the flexibility to overcome the angulation, the ascending aorta. So it has its advantage. It has its disadvantage as well. But now I'm trying to think about either whether in the like less kinky patients should I use like other more stubborn grafts like Cook or like Gore in a branch as a branch device. And if it's really having an angulation, it might be an indications for using the ascending component.
And
Is
what's your pacing strategy? RV transvenous or
yeah, I use transvenous. I did one case as through the we did like a safari wire through the
yeah,
valve, and doing a pacing at the same times deploying the stent. You might actually dislodge the wire up and down, and thus you might some patient, one of the patients just like the pacing got off and the
we've
pressure
seen
back,
that,
and
yeah.
it's just like
Uh,
what's going on. So yeah, from now on I just use intravenous to be honest. I thought.
There's one more question from the audience about would you think lowering the number of branches would reduce the risk of stroke while doing the branching operations? Or
I don't think the problem is the number of branches. Uh, I think there is other issues like as we said, there's air bubbles, manipulations, and high risk patient with shaggy aorta, as Mo said. So I don't think the problem is the number of branches. I think the problem is the either the patient itself, the disease characteristics, or the you're not flushing your graft nicely.
and what's the outcome, sort of what sort of mid to long term results you've got from? I know it's a small number of cases.
Yeah.
You've got.
So, yeah, so
Did you have?
far,
You said that the reintervention is about a third of the patients. So
yes.
the reintervention is usually proximal, distal, or the branches.
So the intervention of most of the case usually distal extensions. It's because of the progression of disease downwards. So you have to do either a TVAR or go downwards fenestrated, whatever, just to complete the treatment. So that's most of the reinterventions. In terms of branches, I was really surprised because either retrograde branches, antegrade branches, they're quite have a good patency in our series as far as now it's about 1 year 1 year interval. So far we don't have any problem with the branches. The um, the other reintervention actually from if you have like a really stubborn entry, it's like chronic dissections and post-chronic dissections aneurysm. And if you have really stubborn entry tear, even if you have co-opted graft, it doesn't seal it completely, and it takes sometimes in this situation, I usually wait. And so if you do a CT scan at like 6 weeks time, you will find that there is still perfusions, the aneurysm itself. But and that's something I learned from my patients. So after 3 months, I was planning for intervention, trying to plug where the entry tear is. And what I found is that when the repeated CT scan, the aneurysm has sealed completely. So it's just patience as well before jumping in three interventions quite quickly. But the main reintervention is distal extension.
That's very useful to know. I don't think we've got any more questions from the audience. So thank you very much, Ahmed, for this very enlightened presentation.
Thanks, thank you.
Okay, next we've got Professor Matthew Popplewell. He's a assistant professor of vascular surgery in the University of Birmingham and consultant vascular and vascular surgeon in the Dudley group. Matthew, thank you for joining us today this
Hey,
lovely Sunday evening.
yeah, thank you for inviting me. Appreciate it. I'll just get my slides up. Oh,
How can you stop sharing your screen?
Yeah, you can
right.
share that. All right.
Thank you. Can you see that?
Yes, we can see it now.
Okay, that better? Is it all full screen?
Yeah.
Excellent. Thank you to the organisers for inviting me to talk about this today. I'm really going to talk about infected EVARs and explantation. So this is something that hopefully you won't have to come across too many times in your careers. It's reared its head a few times for me, particularly in the last 2 years. I've had two, which doesn't sound like a lot, but it's enough. Don't want any more. Um, so endograft infection, sorry. Endograft infection is a rare complication of EVAR, and it can present in two ways, really, hyperacutely or as an indolent infection. It represents an incidence of around 0.6%. I think that's probably a little bit of an overestimate compared to what we see. I don't think we see that many, but it's definitely something that is rare. And I say they can either present hyperacutely or as more of a chronic or delayed infection. So the acute ones can tend to present as a rupture or bleeding or severe sepsis, whereas you have a more chronic delayed picture where patients often present with malaise, fatigue, borderline inflammatory markers, vague abdominal pain, nausea. And to be honest, these are probably the more common from the ones I've seen. So the risk factors for this, for surgical risk factors, there's peri, intra, and post-operative factors. So perioperative, we know that longer length of hospital stay, infection at an adjacent site recently, i.e. the groin, so things like intertrigo or poor groin quality, recent percutaneous implants. So if somebody's had a recent percutaneous procedure and they've had something like an angioseal that's been used, that can theoretically increase the risk of a groin infection, which then could be reintroduced when you put the device in. All emergency procedures carry a high risk of infection. It's probably because of a breach in sterility during the procedure. And people who are having multiple interventions, again, if you've already got some plastic inside and you're performing further instrumentation, there's always a risk of introducing infection to that graft. Intraoperative causes usually breach in aseptic technique. So we in the angio suite, or if we're doing things in a hybrid theatre or sometimes downstairs in radiology, I'm not sure that the asepsis is quite as good as it is in theatre. And we've definitely seen some data in hybrid cases in the UK where any procedure that's done with an open groin in a radiology suite rather than a theatre grade room increases the risk of infection, although this is becoming rarer with new hybrid theatres opening in most centres. Long procedures always increase the risk of infection. And if you're doing any form of combined procedure that involves a GI or a urological procedure, again, in a case of an EVAR, this is probably pretty rare. The most common one I can think of is you get a patient on the table and you can't catheterize them at the beginning of the procedure, and then they end up having some sort of urological intervention before you do your graft. And post-operative, it's generally wound complications, so groin wound infection, which we know happens in around anywhere between 10 to 20% of patients with an open incision, although I appreciate most EVARs are going to be percutaneous in the future. There are other patient-related factors. You will probably know these, so things like malignancy, immunosuppression, chemotherapy, steroids, diabetes, poor diet, malnutrition, things that are common for any type of infection. So, what are the possible sources of endograft infection? So, most of them we think probably happen at the index operation. So, this is direct sort of inoculation of bacteria into the bloodstream or onto the device from poor handling, groin wound infections at around the time of surgery, patients who have a concurrent urinary tract infection that's not known about at the time of surgery. Those are probably the most common from this review that I found here. There is some evidence that people have an endoleak index operation that they go on to have further interventions, which then may increase their risk of developing a graft infection. And it's about that re-instrumentation, or sometimes it can even be from a direct sac puncture. Again, I appreciate that is probably rare, but we still do that in some cases, particularly when there's an expanding sac that we can't treat by any other means. So when do these usually occur? So the median infection time after an implant is around 25 months, so just after 2 years. And that can range, in this review that I looked at here, this could range from anywhere between 1 and 128 months. These are broadly defined into two types of infection. So an early infection is within the first 4 months, and that's thought to be related to a peri-procedural issue. If it's after the 4 months, it's a late infection, and that's more likely to be a translocation from another source. So again, things like urinary tract infections, probably one of the most common. Chest infections, a bit more rare. But yeah, these are more sort of people who develop sepsis and bacteremia, and then they've got bugs stuck onto the graft material. Symptoms, again, I've sort of been over these already, so it can be acute or more insidious. Most people I've seen with a graft infection, it's been the sort of general fatigue, tiredness, odd temperature, CRP of around 80 to 100. They're just sort of very grumbly, and not often they'll have been under other specialties, so they might have been under the medical team for weeks trying to work out why they're having these temperatures at night time, and then someone decides to do a CT of the body to find out what's going on, and we pick up findings. There is something called the MAGIC criteria, which is used for diagnosis of graft infection. And this is a combination of three things. So clinical and surgical features. So you have major or minor criteria. Major are things like pus, which has been aspirated from an aneurysm sac. If you do have a collection around the sac that isn't in the bloodstream, that can be sampled safely with radiological techniques. That's the definitive way to diagnose an infection and gives you the best options for antibiotic cover. Or if you have an open wound in the groin, or if you've had a limb extensions that's pouring pus out of the side, then you can culture that. If somebody develops a fistula, so either aortoenteric fistula or fistula with the IVC, again, that's is a major feature or a possibility that infection is present. Minor features are more sort of localized clinical features, so erythema, warmth, purulence, discharge and pain, high fever. Radiology, in terms of different scans, there's multiple different scans you can do. You can do a basic CT angiogram, which is the most common, and that can give you features that, confirm an infection. So the presence of gas in the sac is highly suspicious. Air fluid levels within the sac as well. But sometimes it can just be a bit of aortic thickening, and other imaging can be helpful, such as PET-CT or PET scanning, which I'll talk about a bit later. There are other suspicious features that you can get around a graft, so things like expansion, new false aneurysm formation, duodenal or bowel wall thickening, or looks like it's stuck right on the front of the aorta, or discitis, and those are all features that you might see on a scan that help you make this diagnosis. And then there's laboratory, so either direct microbiology or organisms that you've cultured from the bloodstream, which are the two most common ways. The problem is often when patients present, they've often had a lot of antibiotics when they first come through the door, either to the ED department or on the wards, before that you have a chance to get definitive microbiology. So often a lot of the blood cultures are negative, and that makes it really difficult to decide how to treat these patients in the longer term and what antibiotics to give them. So this is a typical sort of feature that you can see on a CT scan. So this is an endograft, which was placed around 3 or 4 months before this image was taken. And you can see there that there's a collection that's formed on the anterior wall of the sac. So before, this is up near the neck. So there's no inflamed tissue there at all. And then you've got this big sort of collection that's coming off the front of the graft there. It's highly suspicious of an infection. Another thing you can do is see a PET scan. The PET scans are good and bad. They're not necessarily definitive. Depends when you do them after surgery. But this scan here shows you've got the isotope, which is showing hot spots in the bladder, the kidneys, but also around the graft there. So it may suggest they've had a concurrent urinary infection or possibly a graft infection. What bacteria cause these infections? So the majority on systematic review are gram-positive, which again fits with the infections being introduced at the time of surgery. So it's more likely to be skin flora from instrumentation. Next most common is gram-negative, which is probably more your bowel and urine type bacteria, and then 10% are fungal related, with the rest being polymicrobial. Which imaging technique is best? I think there's quite a broad range of sensitivities and specificities across all modalities. I think CT is probably the most readily available, easiest to perform. And if you've got high suspicion with other clinical features, then your PET scanning probably isn't helpful in diagnosis. It's probably better to use that when you're monitoring infection. So if you've got somebody that you can't treat surgically because of their unacceptable comorbidity risk factors or high risk of mortality, you may choose to manage these with antibiotics, and you can use these scans to follow up and see whether things are progressing or not. I'm not going to talk about these too much today, but obviously another cause of requiring an explant is the presence of an endo leak which cannot be treated. So we see these patients where they've had multiple interventions for endo leaks. You've relined the top, you've relined the bottom. You might have even put a fenestrated cuff in. You've done some embolization of some lumbars. You've done everything you can. You've injected some onyx into the sac. And it's still getting bigger and bigger. It's still pressurized, and you just can't find where. So that is also an indication for an explant of an EVAR, but that's a slightly different topic. So how do we treat this? I think it's the most important part of the talk, really. So the gold standard for treatment, if you have an infected EVAR, is to remove it and to redivert the blood somewhere else from the body. So you can either do that with an in situ repair, which is now probably the favored way of doing this, or you can do an extra anatomical repair. When I first started my training, people were doing these extra anatomically. So we would open the abdomen, we would debride the tissue and ligate the aorta as close to the renals as possible, and then we would do axillofemoral bypasses either as a bifem or two unifems, and we would put those outside of the surgical field, coming down the lateral side, sometimes around onto the profunda or laterally. But people didn't do very well from that. The occlusion rates are high, reinfection rates of the grafts are high. So now we favour an in situ approach. There's multiple different materials you can use to do that. So you can use prosthetic soaked in antibiotics. You can use a cadaveric graft. You can use deep femoral vein. Those are probably the most common things. And the other option, if you can't do any of that, if a patient isn't fit enough, then you can give them lifelong antibiotics. If you do that, Donald, I don't know if Donald's still here, but I know he's looked at this, and Amra will know. If you leave people on lifelong antibiotics and they've got indolent symptoms, then the median survival is around 2 years. But it is a life-limiting, condition, and it is effectively palliative management. The problem we have with doing this surgery is how do you get the EVAR out? So the majority of EVARs that we put in historically, and most of the ones we put in today, have suprarenal fixation, as you can see at the top of this diagram here. So obviously those are embedded into the aortic wall. So after you've got aortic control through a laparotomy, which is usually by supraceliac at this point, because those struts are often going above the level of the renals and are stuck right into the aortic wall. You need to get it out safely, and you need to try and get all of the graft material out. So you can just pull it. 9 times out of 10, if you do that, then the fabric will just tear, and then you'll leave a remnant in the aorta, which may still have some infection. So this was one of the techniques that was described called the syringe technique. So you take a 20 ml syringe, which is in a sterile pack. You cut the end of the syringe off, and then you effectively sheath the cut syringe over the graft and try and resheath those hooks. So you pull backwards on the graft and try and disengage those barbs from the aortic wall. And this is obviously after you've performed the supraceliac clamp, and then that will then allow you to do your formal repair. There are benefits of this technique. Is syringe is sterile; it's in a sterile pack. You have to cut it yourself with another instrument, with a saw or something, or a scalpel, which can leave a bit of a rough edge. And it's not sort of a pre-made thing. It's something you have to make on the bench at the time of surgery. And theoretically, if you got a sharp end there, you could cause trauma to the aortic wall. So I was a trainee at the time, but I wrote this paper about 10 years ago where we actually used a proctoscope, a disposable proctoscope, to do the same thing. The benefit of using the proctoscope is that it's already it's a made device. You don't have to cut it. It's got a smooth beveled edge. But the negative thing about it is they don't come in sterile packs often because they're not put in sterile places. So you have to soak them in chlorhexidine for 20 minutes before doing this. But it's the same principle. So you're using, I don't know if you can see it here, but there's some silk here. And we use that to wind around each stent so that we try and collapse each stent as we're moving the proctoscope up towards the aortic neck. And then once you get to the last stent and the suprarenal struts, then again, the hope is that when you push forward on the proctoscope and pull back on the silk and also the device that you've got sheathed up, that those hooks then disengage and allow you to pull it out. And this can work quite well. I've seen it where, and with the last one we did, the fabric tore out and the hooks got stuck in there. I think if that happens, there's not a lot you can do about it. You can't really go fishing for the hooks. They're stuck and buried in the wall. You just have to leave them. These are often hairy cases as it is, so it's not advisable to go looking and fishing around for these unless they're staring you in the face. So just to sort of highlight what we did in our last case. So we had a 58-year-old man who came to one of my colleagues' clinics with primary retroperitoneal fibrosis, and this was associated with an aneurysm formation. So he had a 4.5 centimeter AAA, which was infrarenal. He was a smoker, he had hypertension, but he had no other comorbidities. He worked as a painter and a decorator, and seemed fairly fit on paper. We were getting a bit worried about him because although he had a subthreshold aneurysm, he'd already lost a kidney to his retroperitoneal fibrosis and his aneurysm was getting bigger. So we discussed him at length in our MDT to decide what to do. And we actually decided that we were going to treat him with open surgery, even though he had a subthreshold aneurysm. And the reason for this, there's some evidence that if you decompress the aneurysm and perform an open repair, that you reduce the inflammation in the retroperitoneum and you stop that retroperitoneal fibrosis from occurring, which is we thought it was caused by an inflammatory aneurysm. Obviously, we didn't want him to lose his other kidney. So the plan was to get on and do it at a smaller size. So he had his CPET testing, so he had an anaerobic threshold of 11.6, so he was a bit borderline, and his echo and his pulmonary function tests all checked out okay, and he was considered fit for open surgery, so he was going to be planned to be done on one of my colleagues' lists. And in the interim, he was admitted to hospital with melena and hematemesis, with a hemoglobin of 5 in a peri-arrest situation, so he was extremely unwell. He had a CT scan which effectively showed that he had a new aortoenteric fistula. So he had a primary case of retroperitoneal fibrosis that had then caused a aortoenteric fistula with a duodenum. So he was actively bleeding into his duodenum. So at this point, we sort of assessed our options. He was too poorly to consider doing an open repair. And obviously the concern is if he had an aortoenteric fistula that we would then be introducing prosthetic material into an infected field. We don't have cadaveric vein on the shelf, cadaveric artery on the shelf. And you don't really have time to harvest his deep femoral veins while you're in effectively a rupture situation. So we decided to put an EVAR in. Ideally, I would have liked to have put a gore in because it lacks suprarenal fixation, but we didn't have one on the shelf in his size, so we had to put a Cook in, which obviously was obviously has suprarenal fixation, which was less than ideal, but it was what we had to do to get him out of trouble. So we put that in, and he did quite well from that. Transfused him up, and then he went home. The concern here was that then we've put an EVAR into somebody with an aortoenteric fistula, so if that EVAR is going to get infected. We knew that from the point that we did it. So we put him on. We put a PICC line in so that we could give him IV antibiotics over a period, and we tried to settle his sepsis down, wait until his aneurysm, his albumin had improved, and then tried to pick an optimal moment for doing an open repair where we would remove the EVAR and then perform an open repair when things had settled down. So we waited for 12 weeks to do that. And planned an elective removal of the graft. So we did that as three of us together. We had to use cadaveric aorta for this, and the reason for that was the retroperitoneal fibrosis had actually caused an IVC occlusion as well. So he had huge venous collaterals all up his retroperitoneum, like the massive, massive varicosities all over the back of his abdomen, which were obviously quite challenging at the time of open surgery. So we actually used a cadaveric aorta, which was from Lemaitre, which was pre-formed, and we stitched that in. He did quite well from that. We used the proctoscope technique and the fabric tore, as I said before, and left the suprarenal struts in place. He had dialysis for a couple of weeks because we had a supraceliac clamp for about 30 minutes while we were trying to get the graft out and stitch things back together. But he did really well, came back to see me in clinic. We grew a vancomycin-resistant enterococcus from his graft, which is less than ideal. I don't know how we got that. It's not that common an organism to be in your duodenum. He did have a stay on ITU during his first operation, and we wonder if it was related to a line infection. But he was on the correct antibiotics for that. But unfortunately, he died 6 weeks after with an upper GI bleed from a duodenal ulcer higher up, almost by the stomach. So he'd bled from that, unfortunately, and it had bled 2 days before but didn't come into hospital, and then just had a huge bleed in his car. So it's quite a sad story, really. But I think we did as much as we possibly could. So this is an example of a cadaveric aorta. So you can get just one tube, and we were lucky enough that we had the whole aorta from almost from diaphragm down to sort of column iliac. So we had all the branches there, which we tied off and stitched off with some Proline just to make sure that it obviously didn't bleed. And then we used the two limbs that were coming down. So we actually managed to do a very short bifurcated graft using just one piece. If you don't have enough aorta with cadaveric material, you can order SFAs and things like that to make a bifurcation that you can stitch together. And you can also do that with deep vein. So we've done another one recently where we've taken the deep femoral vein from one leg, quite a long segment, cut it in half, so we've got two pieces, and then spliced them together to make one big tube to use as an aorta. Obviously, the benefits of that are it's your own tissue, it's less likely to get infected. There are some cases of cadaveric aorta becoming very distended and aneurysmal, some months to years down the line, and with some early blowouts as well. We haven't had one, but there's a couple. I know a couple of people locally that have had blowouts within the first sort of month of putting these in. That may be an immune-related thing. I don't know. So people are rejecting it. I don't know. We don't really know why it happened. The whole thing fell apart. So if you look at survival after different materials used for in situ reconstruction, you can see if you use autogenous vein, the survival at 60 months is about 71%, whereas if you use a prosthetic, it's 12, and that's likely due to reinfection and rupture. Prosthetic soaked in antibiotics isn't bad, 50% at sort of 4 years, but in an ideal world, you would always use a vein. I don't think cadaveric really comes under this. This was just for deep femoral veins. I don't really know where cadaveric sits, but probably somewhere between prosthetic, soaked in antibiotics, and autogenous, I would imagine. I've been through all that. So lastly, conservative treatment. So there is a paper from some guys in Sweden that had looked at conservative treatment. So this is for people without any form of fistula, without any form of rupture, just these generic symptoms that we talked about. And they managed everybody with antibiotics plus or minus adjunctive procedures. So that was things like relining if required, draining any collections percutaneously, antibiotic therapy. And they actually reported quite a good patient survival. But I think this was a highly selected group of people who probably had quite low-grade infections or less aggressive organisms. But they reported 79% survival at 3 years with that. I'm not sure. Again, it's quite a highly selected group, but in some patients, you can get good results with that. And that's it. I'll take any questions if anyone's got any.
Thank you, Matt. It was a very, very interesting talk. It's a difficult subject, I have to say, and they're all tricky patients. From an MDT approach, how do you look at these patients?
I think none of us take these on alone. I think that's the key thing to say. In that patient, that case as I presented, at every single step of that patient's care, we had a discussion at an MDT with multiple surgeons. His operation, there were three of us scrubbed, so me and two of my colleagues who have done a lot of these before. By doing a lot, they've probably done seven in their career, six or seven. So it's not something anybody has done a lot of that I'm aware of. Everyone's done a few because you have to. But they're very, very challenging operations. I mean, particularly the infected ones. I mean, the dissection is pretty horrible, if I'm honest. Lots of inflamed tissue, everything bleeds, no tissue planes. It's really difficult to get control in the infrarenal sort of segment. So often we'll start supraceliac and then clamp and then try and move down if we want the grafts out to move the clamp down. But that it makes it sound slick when you're pulling it out with the tube and things, but it's pretty difficult to do. It's not, they don't just glide out unless they're literally swimming in pus, which most of them are all stuck, inflamed, horrible tissues. But yeah, we really think very carefully about every step, and I think every patient is different. I don't think there's a one.
Our own experience is that actually involving the ID team early on is also very beneficial. They usually have some good ideas and some antibiotics we've never heard of. And I think it's also very important that you do not take these patients on in the acute stage, because it's really horrible to do that. You need to give them a few weeks to just get the acute inflammation down a bit. And also build up the patients, because they usually present quite cachectic, low albumin, really unwell, and you need to build them up for that to give them a good fighting chance to survive this sort of procedure. Ahmed, do you like to add anything?
Yeah, just about the graft usage, because Matthew, you said interesting thing about using cadaveric, and um, some people like quite reluctant to use that kind of graft in aortoenteric fistulas. They said it's like there's a rapid deterioration of the graft. They become aneurysmal later on. Is there any data to say anything about this? And is it comparable to other like a graft that is actually antibiotic impregnated or graft resistance or bovine even? Has there any been a comparison in the literatures about these grafts?
I think you're right. I think we haven't had it ourselves, but well, before I went there, we had one. My colleagues had one before I started working there, where they blew out within 48 hours. But that's again probably a pressure related thing. But I have had colleagues at other units where after a month they've had these massive aneurysmal blowouts and then ruptures. I think the only reason I would use it is if I didn't have any vein. So in this chap, for example, we had vein, but he'd had a DVT 6 weeks before. It was only a calf vein DVT, but he'd also had an occluded IVC, and he had no veins in his arms. So we were like, well, what else are we going to use? The other option, like I said, would have been antibiotic impregnated grafts. But I don't think the problem is with all of this is there's not huge numbers in the literature. You're comparing small retrospective series from single centers over often quite long periods in time, even a decade or so. So I don't think there's a definitive right or wrong answer for that. I think you have to use the best thing you can that's available at the time, that's suitable for the patient.
I think in the south, and I think Mo as well will correct me, that we use more a bovine
Yeah.
patches that we sew together and make like a tube grafts or
Yeah.
bicuspid graft.
Yeah,
There is
I think
also
you're definitely right. It saves, obviously the gold standard is and will always be deep vein,
Yeah.
but it's just the added, 2 hours of surgical time and exposure, etc., is probably balanced out in a very unwell patient. And the
Yeah.
bovine seems to have done very well so far. And I think the St. Thomas's team
Yeah.
have published or are publishing the longer term outcomes. They've been doing it for I think about 12 years now.
Yeah.
And so far they haven't had trouble, so I think that's a good one. But you're
Do you
you're
guys
quite
work
right.
in
We're seeing
cardiac
these.
centers?
Sorry?
Do you guys work in cardiac centers?
Yes, yeah.
Yes, but
Yeah.
we
So
uh, but we use the standard sort of Lemaitre patches that
yeah.
that we use for carotids, but they just come in a bigger sheet.
So you use Xenoshores.
Yeah,
Yeah. Yeah. Yeah.
Biometra has also got now carotid bovine
Yes.
arteries, which
Yeah.
I think will become
Yeah.
very handy in this. I don't think they're widely used yet, but I think they will probably become more popular from the patches because again, it saves a lot of the stitching and the leaks from the stitch line, etc., etc.
Yeah.
definitely.
So I've seen these, and the good thing about them is, like you said, they're an artery, they're longer, and they're also going to use them for early cannulation grafts for dialysis patients.
Yes.
The issue is the maximum length is about 15 centimeters.
Mm.
So as long as I mean, I guess you could put two together, right? But then it's like, well, you got the same issue as using other things. But
They've
we
got
haven't used
longer
one yet.
ones, Matt. I've seen one
Have they?
recently, and it's 50.
50.
Yeah,
Wow.
50. Yeah, which I think will be quite handy. Yeah.
Yeah, that'll be
So
a lot better.
the other question, Matt, if you have an enteric fistula, just for the audience as well,
Yeah.
you of course have a general surgery on time, just trying to repair it primarily, or even take the bowel out. Do you cover all your patients' omental flap? Uh,
Yeah, so with this particular case, we had a general surgeon involved. The fistula had actually sealed
mm,
when we went back in, so there was no hole. We could see where the hole had been,
yeah.
and we basically buried that and put some PDS stitches to envelope the bowel over the hole to sort of reinforce it. And like you said, the sac is often a mess, and you can't really use it to cover things. So we used an mental patch to cover the graft afterwards.
The
Um,
last thing for you, just for the patient, the paper that you have put at the end, which is really, I have been reading about it as well. From the paper's number, I think, can you get anything about the patient's criteria that could be suitable for that kind of treatment, which is a conservative treatment? You definitely say patient with no fistulas.
yeah,
Are they the patients that have like small collections around the arteries? They have only symptoms with suspicious pictures
yeah.
on the scan and CT scan, but they are looks well in themselves. Because I have seen the patients in immunosuppressions and they have infected aorta, and with just antibiotics, we managed to cross the problems for about 2 to 3 years now without an issue. So I think the next step is to know which patients that needs to be treated conservatively with antibiotics. And we have like a selection criteria for these patients, or which patients that we need to be aggressive and do the surgery. Did you get anything from the papers that can tell you the criteria of these patients?
I agree. I think they all had to be. There was about only about 42 patients, I think, in the Swedish review, and most of them had to basically have uncomplicated infection, and were sort of low risk of low bacterial load, etc. And they tended to be quite older and frail as well. Um, you're right. I think the question is, do some of these actually have infections as well? That's the question, because we do get some patients where they have these generic symptoms and the CT it looks a bit inflamed, and you do a PET scan and there's a suggestion there might be something there, but they never
Borderline
really,
patients.
yeah, and they never really do anything. Like they don't ever get sick from it, but they've just got a bit of a grumble, and you have them on antibiotics, and the CRP just bobs around, and those are probably more the patients I would opt to leave on antibiotics. And certainly we've had people on them for 4 or 5 years without any issues at all. But you wonder, have they got an infection? But then it's like, well, I don't really want to stop the antibiotics because if they do and it gets much worse, then they could be in trouble. So you just tend to leave them. And I don't think it's a bad treatment for some people. I think it's the right treatment for some people.
Well, from our experience, because we do have quite a few of these, and unfortunately, these are usually thoracoabdominal repairs with infection, and the surgical reconstruction option is not there to start with. And I think what really matters is if the ID doctors manage to get what type of bacteria they've got and the virulence of the bacteria, and that makes a lot of difference. Because if they know what they're dealing with, and if the patient is lucky enough not to have Pseudomonas or VRE or etc., etc. I think these patients could do quite well with antibiotics. Patients, for example, will get Pseudomonas, or particularly the multi-resistant type of Pseudomonas. I don't think they will do well with whatever treatment you give them, essentially. So I think that's also a factor, getting ID involved, trying to get some blood samples. Now we do routinely take, when we do interventions on these, try to take blood samples from the area of the infected one way or the other to see if that will grow anything to help guide the antibiotics.
Yeah, I think that's key. If you can get microbiology, you can culture something, it's a massive help because, again, we've had a few patients where you don't get anything and you know they've got an infection, but you just can't grow anything from anywhere and you kind of like stuck really. We don't know what do you give them. You have to give them something broad spectrum and hope that that covers things. But it can be difficult. You're right.
Yes, and some of the atypical also infections like Candida, for example, or etc., also makes things quite tricky to diagnose.
Yeah, I would have a low threshold for putting an antifungal in if you're not getting the appropriate response with IV antibiotics. I'd have a low threshold for doing that. As I said in the data presented there, 13% of people have fungal infection, and then another 10% are polymicrobial. So that could be a quarter that could have an element of fungal infection.
Mustafa Abbas asked about the Pomac patch, which we've already sort of answered, but
Yeah.
he's asking about data or evidence, and I don't think there is any strong evidence in this sort of.
No,
Okay,
not that I'm aware of. No.
Mo, you've got to.
Thanks. Matt, just one further question. Do you have sort of a specific pathway or pre-op plan for standardized for all these patients, or do you do it sort of case by case?
I think it's case by case. I think the difference is that the presentation is so different. So, like that chap I presented there, we knew he was going to get an infection because we put a graft in when we knew he had an infected field. Where I've had, had a 90-year-old that we stented a month ago who came in with back pain, severe back pain, and sort of peri-rupture, and she's got an infected aorta, and we stented that. So I think for the chronic ones, personally, I would leave them for once you've got on top of their infection, I would leave them 3 months. I think there's definitely a sweet spot. I think if you wait too long, with the bad infections, ones that don't settle fully with antibiotics, you're going to get deconditioned. So I think there's definitely a sweet spot to do that. But I think the patients are also different. It's hard to sort of fully protocolize things.
And I
I
mean,
think
in terms of the ones that you plan on explanting, would
yeah,
you proceed immediately? Because most of the time they have lost a bit of weight, they are a little
yeah.
deconditioned. Would you keep them in for a while and try and optimize them nutritionally and things like that, or would you just go ahead?
Um, I, I think it's difficult. I know some people will give people, to keep them in and put them an NG tube in and feed them like that. I don't think there's any evidence that improves outcomes by doing that. I think each patient you've got to try and find that sweet spot, and I think in practice it is difficult. I wouldn't want to leave them longer than 3 months, personally, if I'm going to do it, because they're not going to get any fitter.
No, you're right.
No,
I
they're
think
not
we
going to
we
get.
anecdotally keep them in for about 2 weeks and sort
Yeah.
of not NG feeds, but more sort of Fortisips and Fortijuice and high caloric intake and just try and build them up as much as possible. But you're quite right. There's a point where they might fall off their perch and then you've missed that window.
Well, I don't think there's any further questions, so thank you very much, Matt, for your talk,
No
and
problem at all.
thank
Thank you for
you
having me.
for coming and joining us on a Sunday afternoon as well. Thank you, Ahmed, as well for your talk. I know Donald is gone, so I will.
Thank you later.
I'll thank him later. Yeah, and thanks for the panelists as well and all our team, Michael and Habiba. And any questions from the attendees? Anything you would like us to answer before we go? doesn't look like. So thank you very much, everyone, and have a pleasant evening.
Thank you, Bye-bye.
Thank
Thank you
you.
very much, Om.
Thank you. Bye.